Welcome and thank you for standing by. At this time, all participants are in a listen-only mode until the question and answer session. Today's conference is being recorded. If you have any objections, you may disconnect at this time. I will now introduce your conference host, Ms. Laura Morrell. Ma'am, you may begin.
Thank you, Catherine. Good afternoon, everyone. My name is Laura Morrell, and I work in the One Health Office of the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of the One Health Office, I'm pleased to welcome you to the monthly Zoonoses and One Health Updates call on September 4th, 2019. ZOHU call content is directed to epidemiologists, laboratorians, scientists, physicians, nurses, veterinarians, animal health officials, and other public health officials at the federal, state, and local levels. Please be aware that CDC has no control over who participates on this conference call. Therefore, please exercise discretion on sensitive content and material, as confidentiality during these calls cannot be guaranteed. Today's call is being recorded, so if you have any objections, you may disconnect now. Detailed instructions for obtaining free continuing education are available on our website and will be given at the end of this call. Today's presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. The Planning Committee reviewed content to ensure there is no bias. CDC did not accept commercial support for this activity. CDC, our planners, presenters, and their spouses or partners disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Before we begin today's presentations, Dr. Casey Barton-Baravesh, Director of CDC's One Health Office, will share some news and updates with you.
Thanks, Laura. Hi, everyone, and thank you for joining us for today's ZOHU call, and welcome to all of our new call participants. The ZOHU call audience continues to grow with subscribers representing professionals from government, non-governmental organizations, industry, academia, as well as students. We appreciate your help spreading the word about the ZOHU call. Please continue to share the ZOHU call website link with your colleagues from human, animal, environment, and other relevant sectors. The site includes links to past call recordings, information on free continuing education for a variety of professionals, and a link to subscribe to the ZOHU call email list. To begin today's call, I'd like to share highlights from the One Health news from CDC included in today's ZOHU call email. CDC is conducting a survey of large animal clinical practitioners, which is open through October 31st. Also, vector control for environmental health professionals training is available on CDC's website. Some upcoming observances and events include September being Food Safety Education Month. Of note, September 28th is World Rabies Day, and we'll be hearing about rabies risks in the U.S. during one of today's presentations. The Rabies in the Americas Conference will take place at the end of October, and abstracts are due on September 15th for the Inform 2020 conference. We've shared links to recent publications on several topics, including suicide and deaths among veterinary professionals, estimating the effectiveness of vaccine programs in dog populations, and antibiotic use in the United States. Highlighted MMWR topics include updated CDC recommendation for the serologic diagnosis of Lyme disease, outbreak of Salmonella Newport infections with decreased susceptibility to azithromycin, and West Nile virus in the United States. Regarding outbreaks, a new outbreak of Listeria infections has been posted. The outbreaks of Salmonella infections linked to backyard poultry has been updated, reflecting over 1,000 cases in 49 states. And the outbreak of multi-drug-resistant Salmonella infections linked to contact with pig ear dog treats has also been updated. Note that we'll have a presentation about this outbreak during the October ZOHU call. A selected list of ongoing and past U.S. outbreaks of zoonotic diseases, as well as information on staying safe and healthy around animals, is available on CDC's Healthy Pets, Healthy People website. The complete CDC current outbreak list, including foodborne outbreaks, is available at cdc.gov/outbreaks. As always, if you would like for us to share news from your organization, or if you want to suggest presentation topics or even volunteer to present, please contact us at zohucall@cdc.gov. Again, thanks for your support of the ZOHU call and for joining us today. I'll now turn the call back over to Laura.
Thank you, Dr. Barton-Baravesh. Today's presentations will address one or more of the following objectives. Describe 2 key points from each presentation. Describe how a multi-sectoral One Health approach can be applied to the presentation topics. Identify an implication for animal and human health. Identify a One Health approach strategy for prevention, detection, or response to public health threats. And identify 2 new resources from CDC partners. Questions for all presenters will be taken at the end of the call. Call 1-800-593-8936 and enter participant passcode 9611836. Press star 1 and give the operator your name and affiliation. Please name the presenter or topic at the beginning of your question. You'll find resources and links for all presentations on our website and in today's ZOHU call email. Our first presentation, Fungus Among Us, 3 Fungal Lung Diseases in the United States, will be given by Caitlin Benedict. Please begin when you're ready.
Great, thank you. Good afternoon, everyone. I'm very happy to be joining today to give you a quick introduction to 3 fungal diseases that are often overlooked but represent an important problem for public health. And the diseases are blastomycosis, coccidioidomycosis, and histoplasmosis, which are kind of a mouthful to say. It makes them a little more difficult for messaging because they're not very catchy names. The way that people get these diseases is by inhaling the fungi from the environment. There's a very wide spectrum of illness. It can depend on the inoculum size and the host immunity. So many people are exposed, but they never get infected. Some people will develop asymptomatic infection. And then among people who do get sick, pneumonia is usually the most common presentation, and the smaller proportion of people will go on to develop disseminated disease in other body sites, which can be fatal in some cases. And one of the main challenges with these diseases is that they're very difficult to recognize because the signs and symptoms are nonspecific, things like cough, shortness of breath, and fever. So they're identical to symptoms from other causes of pneumonia. And this leads to a lot of empiric treatment for suspected bacterial pneumonia. It's not uncommon for people to get multiple courses of antibiotics before they're correctly diagnosed with a fungal infection. Also, these diseases often affect previously healthy people and animals, so sometimes it's several weeks before a fungal infection is even suspected. And then to add to this problem, it can take a long time to get some lab test results, and some of the serologic tests that are commonly used to diagnose these diseases have limited sensitivity and specificity, although there are some newer tests that appear to be more promising. And now I want to talk a little bit about each of the 3 diseases in more detail. So starting with blastomycosis. This is a map showing the areas where the fungus that causes it is typically thought to live, but do take this with a grain of salt. The fungus seems to like moist soil and decomposing wood and leaves around waterways in these areas, but it's only been isolated from the environment a few dozen times. And we suspect that these geographic areas are changing. So for example, there have been some cases in eastern upstate New York, and there was an MMWR article that came out about that last year. But it's difficult to understand exactly where blastomycosis is newly emerging because it's only a reportable disease in 5 states. So it makes it a little bit more difficult to track, although we aren't aware of any major trends. Overall, it's pretty uncommon, although Wisconsin sees many cases where the incidence can be much higher in some areas. And one thing that we do know is that blastomycosis is in some places just as common in dogs as it is in humans, so dogs can be a good indicator of where the disease is because often they share similar exposures with their owners. And switching gears now to coccidioidomycosis, or valley fever. It's really heavily concentrated in Arizona and California. That's where about 95% of the reported cases come from. But we've also seen outbreaks and cases as far north as Washington State in the last decade or so. And it's a reportable disease in about half of states. So this is surveillance data reported to CDC. It's based on state of residence. So most of the cases that you see outside of the western U.S. are travel associated, which presents additional challenges for clinicians recognizing valley fever outside of the areas where people actually get infected. And we see about 10,000 to 15,000 cases every year. We've seen an increase in the past couple of years. I don't have it here on the graph, but the preliminary data for 2018 and 2019 are also showing an increase. And we think that some of these trends may reflect changes in testing and reporting cases to public health, but they also do appear to be at least partially real and related to environmental factors like temperature and rainfall. And finally, histoplasmosis. So these areas were identified in the 1940s and 1950s using skin testing. And similar to the maps that you saw for blastomycosis and coccidioidomycosis, we know that this map may be a little bit outdated. Histoplasmosis also has a unique kind of zoonotic component in that the fungus survives especially well in association with large amounts of bird or bat poop. So we do see histoplasmosis in pockets that are outside of these areas also. And this map shows some more recent data. This is surveillance data showing county-level incidents from the states where histoplasmosis is reportable. And compared with the previous map, you can see a lot more cases in the upper Midwest. And I'll leave you with one last map. So this one is based on environmental modeling and seems to suggest that there may be some suitable environments, habitats for histoplasma even farther to the north and the west of the typical areas. So for all three of these diseases, because people get them from the environment, they're difficult to prevent. There aren't any vaccines, although there have been a couple of attempts to make one for coccidioidomycosis. Sort of common sense method for prevention would be for people who are at higher risk of getting more severe infections to try to avoid specific areas or activities that are known to be associated with these diseases. So for example, with histoplasmosis, that could be something like cleaning out a chicken coop. We don't know for sure whether personal protective equipment is effective, but we think it could be helpful for reducing exposures in certain situations, particularly in preventing work-related illnesses. Valley fever and histoplasmosis, they both have a big occupational health component. So really what we try to focus on in terms of prevention is early diagnosis as sort of the best secondary prevention method. And because these diseases affect both people and animals, often pets, a One Health approach I think is useful to keep in mind here. So cases in animals help us better understand the geographic distribution of these diseases. And I think we still also have a lot to learn about how animals may play a role in spreading these fungi. So the association with birds or bats that I mentioned for histoplasmosis, and there's some discussion about the role that rodents play also in the life cycle of coccidioides. So to summarize, I want to leave you with a couple of main points. And the first is that these diseases can have really serious morbidity. A lot of people can be sick for weeks, months, or even years. Recently, we estimated that altogether, these three diseases cost nearly $450 million each year in direct medical costs, but we know that the indirect costs are sure to be much, much higher than that. These diseases are becoming recognized more and more outside of their typical areas, so it's important to be on the lookout for them in places we might not expect. And they can be difficult to diagnose and to prevent, so spreading awareness is one of the most important ways that we can help reduce delays in diagnosis and treatment, which can lead to better health outcomes and save lives. That's why we are holding our third annual Fungal Disease Awareness Week on September 23rd to 27th. We'll be coming out with several new publications and resources around that time, so we hope that you can join us in sharing some messages on social media. That's all I have.
Thank you. Our next presentation, Rabies Risks in the United States, Shifting Focus from Dogs to Wildlife, is by Dr. Emily Pieracci. Dr. Pieracci, please begin when you're ready.
Thank you. Good afternoon. So today I'm going to be discussing rabies trends in the United States from 1938 to 2018. And this data was recently published in MMWR's Vital Signs report. So rabies virus infection causes an acute progressive encephalitis. Exposure occurs primarily through a bite or a scratch when virus in the saliva is introduced into a break in the skin. Multiple variants or strains of the rabies virus exist and circulate in multiple animal reservoirs or hosts. Rabies virus infection regardless of the variant or animal reservoir, is fatal in over 99% of cases. Globally, there are more than 59,000 human rabies deaths every year, and over 98% of those deaths are associated with bites from rabid dogs. In the first half of the 20th century, the greatest rabies threat in this country was from dogs. However, mass vaccination of dogs and strict leash laws, which began in the late 1940s, helped to significantly reduce both dog and human rabies cases. Today, the U.S. is considered canine rabies virus variant free, and the elimination of the canine rabies virus variant is considered one of the greatest U.S. public health achievements in the last century. At the beginning of the 20th century, there were between 30 and 50 human rabies cases a year in the U.S., whereas now we have 1 to 3 human cases per year. And this graph shows domestic animal cases in red and human cases in the dashed blue lines. Over 100,000 animals are tested in the U.S. every year, and approximately 5,000 animal rabies cases are diagnosed annually. 92% of animal rabies cases occur in wildlife species. Animal rabies reservoirs in the United States include raccoons, skunks, foxes, bats, and mongoose in Puerto Rico. And the rabies virus variant distributions in these reservoir species are shown on the map. Rabies is found in every state except Hawaii. Over the last 80 years, there has been a significant decline in domestic animal rabies cases, likely due to vaccination efforts by veterinarians, public health officials, and animal advocates, and what appears to be an increase in wildlife animal rabies cases. But this could be due to several factors, including improved surveillance and laboratory diagnostic capabilities, leading to better detection of cases, or it could be due in part to an increase in human-animal contact as the human-urban environment encroaches into wildlife settings. During 1960 to 2018, among the 125 reported human rabies cases, 89 were U.S. acquired, including 6 organ transplantation cases. Among the U.S. acquired cases, 70% were caused by the bat rabies virus variant. There have been 36 cases of rabies that were acquired by U.S. residents while traveling abroad and due to bites from rabid dogs. Roughly 55,000 people receive post-exposure prophylaxis, or PEP, every year for potential rabies exposures. That's 1 person every 10 minutes. The majority of exposures are bites or scratches from unknown dogs and cats that are unavailable for the 10-day monitoring period outlined in the National Association of State Public Health Veterinarians Rabies Compendium. Not everyone who receives PEP had a confirmed rabies exposure. We know that we overprescribe PEP in the United States, but with a nearly 100% fatality rate, we simply can't take the chance of leaving a patient untreated. The cost of PEP varies considerably. We found an average cost of $3,800 for a complete course of vaccine and rabies immunoglobulin, not including wound care treatment or other hospital expenses. Previously published data and current average sales price data from the Centers for Medicare and Medicaid were used to estimate the cost for this analysis, but the actual amount that hospitals bill patients for PEP varies considerably, and this makes it difficult to assess the true cost of PEP. When assessing why so many people have died from bat rabies in the United States over the last 60 years, it's important to note that bat bites and scratches are small and can be very difficult to detect. Cases occur year-round, as many bat species live alongside humans in urban environments, roosting in attic spaces, the walls of homes, or even under bridges. Rabies vaccination of bats is currently not feasible, and the prevention of human rabies infection from bat rabies will continue to rely on secondary intervention methods such as health education, exposure prevention, and administration of PEP. Despite the rabies exposure risk, the vast majority of bats submitted for testing, approximately 94%, do not have rabies, and therefore widespread killing of bats is not recommended to prevent rabies, as bats are valuable contributors to our ecosystem. There are approximately 175 mass bat exposure, or MBE, events every year. MBEs are defined as an exposure of 10 or more people to a bat. MBE investigations are time-consuming and costly, as public health departments must conduct individual risk assessments for potentially exposed persons. Educational messaging that emphasizes avoiding contact with bats and seeking care immediately if one has contact with a bat may help to reduce exposures or at least alert public health officials sooner to potential MBEs when they occur. Next to bats, the second leading cause of human rabies deaths in the United States is due to dogs, specifically rabies acquired by travelers when they're abroad. Canine rabies is present in more than 120 countries worldwide, shown on the map in purple, as many countries don't yet have the ability to implement sustained mass vaccination campaigns that would reach sufficient levels of vaccination coverage to eliminate canine rabies from their country. General prevention messaging includes avoiding contact with wildlife, seeking care if bitten or scratched by an animal, and vaccinating domestic pets to protect people and their families. Healthcare providers can contact state and local health departments for assistance with rabies exposures, risk assessments, and PEP recommendations for individuals or groups of persons exposed. Healthcare providers should ask patients about recent animal bites or scratches, as many individuals are unaware of the risk of rabies in the United States. While bat rabies may present a risk to people in the United States, it's important that everyone understand worldwide canine rabies still exists and continues to be a risk for travelers. Travelers should be cautious and avoid contact with unknown animals while abroad. Check with a healthcare provider prior to traveling to discuss rabies vaccination recommendations and have a plan to get help if the traveler is bitten or scratched while abroad. Thank you.
Thank you. Our final presentation, Cryptosporidiosis Outbreaks in the United States, 2009 to 2017, is by Dr. Radhika Garpur. Please begin when you're ready.
Great, thank you. Good afternoon, everyone. My name, as Laura mentioned, is Radhika Garpure, and I'm an EIS officer in the Waterborne Disease Prevention Branch at CDC. Today I'll be speaking about cryptosporidiosis outbreaks in the United States. I'll start off by providing some background on cryptosporidiosis, which I'll refer to as crypto for short. Crypto is a diarrheal illness caused by the Cryptosporidium parasite, which is pictured here. Diarrhea from crypto is profuse, watery, and prolonged, lasting for up to 3 weeks. People who are at increased risk for severe illness include young children, pregnant women, and people with weakened immune systems. The parasite is shed in the feces of infected humans or animals. It can be transmitted through ingestion of contaminated water or food, or through contact with infected people or animals. One of the qualities that makes Cryptosporidium unique from other enteric pathogens is the fact that it's highly tolerant to chlorine. It can survive in properly chlorinated pools for longer than a week and can survive on surfaces that are disinfected with chlorine bleach. Another factor that makes crypto challenging to control is the fact that the parasite is shed in feces in amounts that are many orders of magnitude above the infectious dose. An infected person can shed up to 10 to the 8th oocysts in one diarrheal incident, and the infectious dose is 10 or fewer oocysts. These oocysts are immediately infectious upon excretion. Crypto is the leading cause of waterborne outbreaks in the United States, and specifically the leading cause of outbreaks associated with treated recreational water, meaning the water we swim in venues like pools and water parks. Crypto is also a leading cause of enteric infections attributed to animal contact. Bovine calves in particular are susceptible to crypto and can shed large numbers of parasites into the environment. A number of other animal species besides cattle have also been involved in crypto outbreaks. Knowing the public health importance of crypto, we wanted to describe the epidemiology of crypto outbreaks in the United States. To do so, we examined outbreaks reported to CDC. Public health officials in U.S. states and territories report outbreaks to CDC through the National Outbreak Reporting System, or NORS. NORS collects reports of enteric disease outbreaks transmitted by 5 modes, which are animal contact, person-to-person transmission, environmental contamination, waterborne transmission, and foodborne transmission. Our analysis included crypto outbreaks reported to NORS, with onset from 2009 through 2017. 2009 was the first year of NORS reporting, and 2017 was the most recent year for which data were available at the time of analysis. I'll now share the findings of our analysis. For the period from 2009 to 2017, public health officials from 40 states and Puerto Rico reported 444 crypto outbreaks. These outbreaks resulted in 7,465 cases, 287 hospitalizations, and 1 death. Over half of outbreaks were reported from the 8 states in the Great Lakes region. The most commonly reported cause of crypto outbreaks was exposure to treated recreational water, which led to about 1/3 of outbreaks. These outbreaks represented more than half of all cases and about 2/3 of all hospitalizations. The most common recreational water venues included swimming pools, kiddie pools, and water playgrounds. The second most common cause was contact with cattle, which led to about 15% of outbreaks. And the third most common cause was contact with infected individuals in childcare settings, which led to about 13% of outbreaks. We examined trends over time using a negative binomial regression. We found that the number of reported crypto outbreaks increased by an average of about 13% per year from 2009 to 2017. Specifically, outbreaks associated with cattle contact increased by an average of about 20% per year. Outbreaks associated with childcare settings also increased by an average of about 20% per year. And finally, outbreaks associated with treated recreational water increased by an average of about 14% until 2017, when there was a decline. Overall, when we looked at crypto outbreaks by month, we saw that they peaked in the summer, in July and August. Specifically, we saw a summer seasonal peak in waterborne outbreaks, mostly driven by swimming and recreational water activity during the summer. There was also a summer seasonal peak in person-to-person outbreaks, mostly driven by childcare settings, since young children might be using the pool during the summer and then bringing crypto to their daycares. Outbreaks associated with animal contact had an earlier peak in March through May, which might correspond to the spring calving season. I'd like to note that our analysis is subject to at least 4 limitations. First of all, outbreaks reported to NORS likely underestimate the true number of crypto outbreaks in the United States. Also, the reported number of cases likely underestimate the actual magnitude of outbreaks. Also, since about 2015, more diagnostic laboratories have been using multi-pathogen testing panels that include Cryptosporidium. This might have contributed to the increase in reported outbreaks that we observed. We also know that the capacity to detect, investigate, and report outbreaks varies across jurisdictions. The reporting requirements may also vary. For example, it's unclear if half of the outbreaks truly occurred in the Great Lakes region, or whether these states have the capacity to report more outbreaks. Lastly, only about 15% of reports included molecular characterization data, so we were unable to look into outbreaks by Cryptosporidium species and genotypes. Our results really underscore the idea that crypto is a One Health issue and requires a One Health approach for prevention. The most common outbreak exposures represent all three components of the One Health triad, such as the environment we swim in, the animals we interact with, like cattle, and the people we interact with, like in childcare settings. Specific prevention messages for each of these exposures include recommending that individuals not swim or let kids swim if they're sick with diarrhea. Specifically, if they're tested and know that crypto is the cause of the diarrhea, they should wait 2 weeks after the diarrhea has stopped to go swimming. Also, crypto is hard to get out of the pool once it's in the water because it's so chlorine tolerant. So we emphasize that swimmers should avoid swallowing pool water. For animal contact, key prevention messages emphasize washing hands with soap and water after coming into contact with animals or their environment. It's important to note that alcohol-based hand sanitizers are not effective against crypto. Also, we recommend that people remove clothing and shoes worn in animal environments before going inside a home to avoid cross-contamination. Lastly, for childcare settings, key prevention messages emphasize keeping kids with diarrhea home from childcare. Our analysis provided insights that will be valuable to crypto prevention messaging, but looking to the future, molecular characterization methods might further optimize prevention efforts. CDC's CryptoNet is the first U.S. national surveillance system for a parasitic disease that's based on molecular characterization. We know that individual species, genotypes, and subtypes of Cryptosporidium can have unique host ranges, so molecular characterization can help identify outbreak exposures and sources. CryptoNet has already been used in investigations of wreckwater-associated outbreaks, and it has the potential to contribute to other outbreak investigations in the future. If you're interested in reading more, our findings were recently published in CDC's Morbidity and Mortality Weekly Report on June 28th. I'd like to conclude by thanking the many individuals at CDC who were involved in the release of this MMWR and in our communications for Healthy and Safe Swimming Week. I'd also like to thank our state and local health department partners for reporting outbreaks to NORS. Thank you.
Thank you all for your presentation. At this time, we'd like to take questions for any of our presenters. Call 1-800-593-8936 and enter participant passcode 9611836. Press *1 and give the operator your name and affiliation. Please name the presenter or topic at the beginning of your question. And note that Caitlin Benedict has had to hop off early, so if you have questions, feel free to email our box, zohucall@cdc.gov, and we'll pass your question along to her. Catherine, do we have any questions?
At this time, we have no questions in queue. As a reminder, you may press *1 on your touch-tone phone. We do have one question coming through. One moment, please. The first question is coming from Christina Nelson of the CDC. Your line is open.
Hi, this question is for Radhika. Is Radhika still on? I missed who had to jump off.
I am still on, yes.
Okay. Very nice presentation, very interesting. One question, so you mentioned one of the prevention measures is recommending that people who are swimming avoid swallowing the pool water, since crypto is resistant to chlorine. I think a lot of us who have little kids know that that's a very difficult measure to implement. I'm wondering if there's anything new in research or new chemicals or additives that could be added to the pool that would be more effective against crypto than just chlorine?
Yeah, thanks for that question. Since crypto is so chlorine tolerant, our major recommendation is the first one that I had presented, which is just to keep it out of the pool in the first place. So if people are sick with diarrhea, they should not go swimming, and especially if they have crypto, they should wait for 2 weeks to go swimming after their diarrhea is resolved. And if kids are sick with diarrhea, we recommend keeping that out of the pool. So really our best prevention is really just keeping it out of the pool so that we don't have to worry about once it's in the pool.
Right, okay. But there's nothing kind of in the pipeline that looks promising for being more effective against crypto that you are aware of?
We do have some recommendations on our crypto website about chlorine treatment, like shocking the pool, I guess, with high levels of chlorine, but that's really more for kind of commercial operators and kind of larger facilities that have staff to be able to do that rather than backyard pools. So really chlorine in the pool is our best line of defense and only at very high doses.
Okay, thank you.
The next question is coming from Randall Walling, Food Safety Inspection Service. Your line is open.
Hi, this is for Radhika as well. It kind of follows on with the previous question that was just asked, but really my question was, is there any more or less or the same efficacy of using bromine sanitizers versus chlorine sanitizers, or is it just the method of action of all those similar chemicals are the same?
Thanks for that question. I would have to follow up, I think, with our lab team on that. I'm not familiar with bromine-based disinfectant, so I can follow up with our lab folks and get back to you on that if that's okay.
Thanks.
Catherine, do we have any additional questions?
Yes, we do have the next statement coming from Michelle Plaza, Food Safety Inspection Service. Your line is open.
Oh, so I'm from CDC and I work with Radhika, and I just wanted to add to what Radhika was saying about Cryptosporidium in the water and responding to the question. Yes, we do hyperchlorinate public pools, and again, like Radhika said, we do not hyperchlorinate backyard residential pools. The thinking being that the risk of pool chemical injury is greater than the risk of infection, given that people who use backyard pools are more likely to share infection, possibly, or there's likely to be transmission within the household anyway. For public pools, we do recommend the use of UV and ozone to inactivate the pathogen. It inactivates other pathogens as well.
Thank you for that explanation. Catherine, do we have any other questions?
And we do have another question coming from Jillian Yarnell, FSIS. Your line is open.
Hi, thanks for taking my call. I can't remember if you did the presentation on blastomycosis, sorry, but my question is regarding that. So if it's present and exposure can occur in bird feces, particularly chickens, I know you mentioned PPE, but are there any other means of preventing exposure to this in a slaughter facility environment where there's usually a lot of dust and exposure involved?
Thanks for that question. Caitlin Benedict has actually hopped off the call for another engagement, but I've noted your question, and if you'd also like to send it to the ZOHU call email address, zohucall@cdc.gov, we can also forward that on to her and make sure that she responds to you.
Okay, could I ask just one more real quick?
Sure.
Yeah, so for regarding the crypto then, again, exposure in a slaughterhouse environment, you had said, the presenter had said that alcohol-based sanitizers are not effective as far as preventing, both through direct contact with feces happens a lot, and also through dust and potentially aerosolization when they're spraying down the barns. Are there any either other sanitizers they could be using or any other way to prevent exposure?
Thanks for that question. That's a great question. So really our main line of defense against animal contact transmission of crypto is washing hands with soap and water. So I guess as an employer in a slaughterhouse, making sure that hand washing stations and soap are readily available. And it's kind of the standard PPE that would be worn for other pathogens when it's being sprayed down, like masks or, whatever is kind of standardly used, I think would also be helpful.
Okay, thank you.
The next question is coming from Randall Walling, FSIS. Your line is open.
Hi, this was for Dr. Pirazzi. I hope I didn't butcher that name, I'm sorry, about rabies in the human population. Are we getting to a point where we're going to start recommending rabies vaccination in the general population of humans like we did with dogs to try and eliminate that human method as well, since we're doing so good in the domestic population, or is it still being looked at as just simply a risk-based vaccine in humans?
Yeah, thanks for that question. No, you did not butcher my last name. So there's been a lot of discussion within the international rabies community about basically prophylactically vaccinating children in countries where canine rabies is still endemic. And that is something that Gavi, the Global Alliance for Vaccine Initiatives, is looking at. Right now, it is not cost-effective here in the U.S. because we have eliminated canine rabies. And so in the U.S., we continue to use a risk-based approach to determining whether PEP is needed for people. I do think that there is going to be more discussion in the future in countries where canine rabies is still endemic as to whether or not it is going to be beneficial for them to institute, like you mentioned, this prophylactic use of rabies vaccination, specifically in children, to try and save lives. And that's still, it's up for debate, and it's something that the World Health Organization is kind of leading the charge on with Gavi. But we haven't come to any final decisions yet.
Thank you.
At this time, we have no further questions in queue.
Great. I'll give it just 1 second, see if anybody else has any last-minute questions. Okay, Catherine, are there any other questions?
We do have 2 questions coming through at this time. 1 moment, please. John, your line is open. You may ask your question.
Thanks. I work with the local public health department, and the question of Cryptosporidium has come up recently with respect to a private drinking water well, so groundwater exposure. Looking on CDC's website, I see some material there talking about groundwater and drinking water wells as a potential source of Cryptosporidium, and I was wondering if there's any further information about that as to how often that is being seen as a source of exposure.
Thanks for that question. So in the 444 outbreaks that we looked at, only 8 were associated with drinking water, and I believe, I think maybe 2 of those, I would have to check the exact numbers, were associated with private wells. So out of the 444, it was a pretty small percentage amongst SCO outbreaks, but we do have some guidance available for private wells, and I'd be happy to follow up with you on that in the future through email.
That'd be great.
The next question is coming from Chris Polipo, Center for Veterinary Medicine. Your line is open.
Hi, this is Chris Maluso. Thank you for having the ZOHU call. I think it's very helpful to all of us in One Health. I have a question about the crypto. Other than cattle, are there any other domestic animals that we should be concerned about? Barn cats or dogs or whatever?
Sure, thank you for that. So in our analysis, we found that out of the 86 outbreaks were associated with animal contact, 9 of them were associated with goats. There was 1 outbreak associated with sheep. There are also a couple implicated, like you said, dogs and cats. I think raccoons have even come up recently. So yes, a number of other animal species. So that's why our recommendations for washing hands after contact with any animals kind of apply across the range of species.
I also have a question for the rabies presenter.
Sure, go ahead.
I'm a veterinarian. I was vaccinated for rabies when I was in vet school, which is over 30 years ago. And I had my titer tested recently by I think it's the Kansas State Veterinary Diagnostic Lab. And my titer was as high as it could be on their scale. Well, what does that mean? Does that mean that I'm safe if I was bitten by a rabid animal?
Oh, you ask the most difficult question in the rabies world. What does a high rabies titer mean? So the answer to that is we don't really know what a high rabies titer means. We are hedging our bets that a high rabies titer would mean that you would be adequately protected if you were to be exposed to a rabid animal. But if you notice in ACIP guidelines, when you are exposed to a rabid animal, even if you have received pre-exposure vaccination, it is still recommended that you receive 2 booster doses of rabies vaccine on day 0 and day 3. And the reason for that is we're not sure. We don't know for sure whether a high titer equates with protection. And we can't take the chance to find out. With a disease that is nearly 100% fatal, you don't want to be the person that's put in the randomized control group that doesn't receive post-exposure prophylaxis. And so because it's unethical for us to kind of test from that perspective, even if you have been pre-vaccinated against rabies, you are still recommended to receive post-exposure prophylaxis after you've been exposed. But yeah, so bottom line up front, we just don't know whether a high titer would equate with good immunity and good protection against an exposure. Thanks for the question.
Thank you.
At this time, we have no further questions in queue.
Great, thank you. We'll go ahead and conclude. Thank you, everybody, for your questions, and thanks again to all of today's speakers for their excellent presentations. Instructions for receiving free continuing education are available at cdc.gov/onehealth/zohu/continuing education. The course access code is OneHealth 2019. To receive free CE for today's webcast, complete the evaluation at cdc.gov/TCE online by October 7th, 2019. A web on-demand recording of today's call will be posted online by October 2nd, 2019 at cdc.gov/onehealth/zohu/2019/september.html. Our next call will take place on Wednesday, October 2nd at 2 p.m. Eastern Time. Please send suggestions and questions to zohucall@cdc.gov. For more information and to subscribe to our email newsletter, please visit cdc.gov/onehealth/zohu. Thank you for your participation, and this ends today's call.
This will conclude today's conference. All parties may disconnect at this time.